treatment response does it speak? Very often when a child cries, only the mother knows whether the child is crying for hunger or so many other body needs. So similarly, as a treating physician, we have to keep our mind open to listen how does the treatment going to speak back to us. It can be either a positive response, we are really happy when you get it. It can be a negative response, we have to be really skeptical about it. And sometimes it will be plus or minus. So let us illustrate each one of them with the illustrations which we are going to look forward. Sometime when you have a case like hemorrhagic retinitis, you treat with antiviral, there is a beautiful resolution, you are happy. So you have a frost bronchitis, you treat it, it responds beautifully well, doesn't know whether the patient had a disease or not. We are really happy. So these are all the simple situations. Similarly, you see a papillopustular lesion in the hand along with this matted lymph node, and you do a skin biopsy, it showed a tuberculate reaction. You start on ATT, there is a marked resolution of the subretinal abscess coupled with the vision improvement from hand movements or FCF to 6/36. You are pretty sure that you are dealing with on a safer zone. Sometimes positive response also helps us to navigate some difficult cases. So I had a patient with massive splenomegaly, vitals are normal, anterior segment you see a very faint granulomatous escapes with cells and flare, other eye was absolutely normal. You see, look at the fundus, you see a multiple elevated lesion with irregular margin at the macular area suggestive of choroidal lesions. So did an OCT, found some SRF, and as you see in the picture, did an fundus fluorescein angiogram. Again, it shows dull lesions in the early middle phase, becoming hyper in the late phases. We have the differential as usual as tuberculosis, sarcoidosis, syphilis, the routine stuff, along with the masquerade. Ordered the baseline investigation. Now look at the baseline investigated parameters. When we order the investigations, a lot of physicians don't look at the TCDC at all, so you can't ignore that. See, the total count was elevated massively. You don't see a 1,80,000 count or elevated platelets. Then did a peripheral blood smear, did a bone marrow aspiration, as well as fluorescein in situ hybridization, which showed Philadelphia being positive with the ABR-BCL protein. So you got a diagnosis, it is CML in an accelerated phase, and again this patient was started on imatinib and hydroxyurea. So the inflammation resolved, and gradually there was improvement, but the SRF was not showing marked resolution. So we suspected an associated posterior scleritis and did posterior subtine on steroids to treat the SRF, and the vision improved to 6/6. Again, it is a positive response. The beautiful documentation before and after treatment with OCT, and this CML is a myeloproliferative neoplasm with clonal proliferation of mature cells of the myeloid lineage. So the basic here is a Philadelphia chromosome, which codes for the BCR-ABL protein, which is basically a tyrosine kinase, which causes the proliferation of growth of the neoplastic cells. So it has multiple phases, chronic, accelerated and blast phase. Our patient was in an accelerated phase. Usually it has got a poor prognosis. Luckily with appropriate treatment, that was a marked improvement. What is this treatment we are given? It is a tyrosine kinase inhibitor, imatinib, and it works really well in these cases. Why this case? Although this patient was in accelerated phase, there was a marked improvement in the patient getting back the vision of 6/6 like most refractive surgeons these days do. Shifting gears, sometimes we get negative response also, and we are flabbergasted. What I'm dealing with this. So this was one such case. I had a patient with right eye 6/6 when the patient first walked in, otherwise was 1/60. Anti-segment in the right eye was normal, but for the left eye with faint cells. Under macula, there was funny looking lesions around the macula with dull looking multiple retinal or choroidal lesions, you could say. We suspected viral, started oral antiviral along with oral steroid, appropriate MANTU was done. See, after 10 days, the other eye, right eye, which was 6/6, became 6/60. The left eye vision became 6/36. We ordered for additional tests like HIV, HBsAg, and syphilis, and everything turned out to be negative. This was a fundus with multiple subretinal lesion involving the macula with RPE motily. Did an OCT, it showed full thickness hyperreflective lesions and foveal thinning and atrophy. This sort of marked foveal thinning and atrophy is very, very characteristic of this disease entity. Let us see what it is. Did a fluorescein angiogram, again showed multiple hypo, late hyperlesion, At last follow-up, look at the terrible thinning, atrophy of the macula. Like you don't see a marked progression of the disease happening in 10 days or within a month or so, with so much destructive process happening in the retinal layers. So what are the tests we ordered? As we said, HIH-BACG was negative, dengue chikungunya was negative, toxophilix was negative, but this test, measles IgG, was positive. Now you would have got what the diagnosis I am speaking about. Speaking on the course of events, so in a short span of time, the vision which was 6/6 became no PL, and 1/60 there was little improvement followed by deterioration to 5/60. Now, the story is not over. After 5 weeks, the patient developed neurological symptom, disorientation, loss of voluntary reflexes, and latent respiratory failure. The patient was taken over by the neurologist, where they did a CSF tab for the measles antibody, and the diagnosis, is straightforward now. It is subacute sclerosing panencephalitis, and there is a Dykens criteria to diagnose subacute sclerosing panencephalitis, in which the raised titer of more than 1/256 is very characteristic, along with the CSF titers, along with the characteristic EEG findings. There are different drugs used for SSP. It could be an amantadine, cimetidine, steroids, the multiple interferons. The most important one is the isoprenosine, along with intraventricular interferons in a combo therapy, seems to work out well. Usually, this disease, SSP, has got a very poor prognosis. When you read this article speaks about the good prognostic factors in SSP. It says the age of onset, less than 12 years, disappearance of periodic complexes, the tendency to normalization in the background of the EEGs, and the progressive increase in the antibody titers are all going to prognosticate the good prognosis in SSP. When you have such points, you can really calm down the patient, because these patients are going to die soon once they present to you with macular retinitis. So how to diagnose SSP? The most important point is there is little or no vitreous inflammation or involvement of the retinal vessels or satellite lesion, unlike you see in other disease entity. When you happen to see these sort of features, macular retinitis with zero vitritis, zero satellite lesions, be very, very careful that you may lose the patient, and the patients may sue you also if you don't pick up on time. It could be an SSP. Basically, clinicians, you have to suspect when there is a lack of steroid response, you could be handling a very, very severe form of infectious uveitis, or it could be an aggressive non-infectious like Behçet's, or very simple, it could be a fungal entity, or never forget the masquerades, or a metabolic masquerade, as well as an ocular ischemic syndrome. This slide is very, very important whenever you encounter a lack of steroid response in your practical scenarios. So shifting to the last case, this is a plus or minus case. Whenever there is a clash between a clinical sense and investigations, which one you are going to choose? Are you going to believe your sense, or are you going to believe the investigative parameters? Let us see that. So this was a patient who presented with a funny history of evening rise of temperature, and nothing significant from the histories. Anterior segment was pretty okay. The fundus in day 1, right eye was looking normal. Left eye, you see a perimacular or inferior to that, choroidal lesions. The right eye B scan was done. It showed an appropriate RC elevation, shallow retinal detachment, did an OCT, focal ISOS loss. Again, there is an ellipsoid zone loss. Be very focused on this ellipsoid zone loss. SRF was also there, and the RP elevations were also documented along with the RD. So what is my diagnosis? It could be a left eye evolving posterior uveitis, it could be TB sarcoid, or it could be a colloidal melanoma. So after some time, what happened was the right eye again got involved, like in the previous case. Again, there was a choroidal lesions. Did a baseline investigation. ESR was borderline elevated, nothing more. And look at the MAN2. It was 0 millimeters. I never thought this 0 MAN2 could help me further in proceeding the navigating this disease scenario. In the late venous phase, you see a punctate hyperfluorescence, and there is an incline fluorescence in the late phase. In the arterial phase, you see a punctate hyperfluorescence again in the left eye, it becoming more in the later stages, hypo becoming hyper. Did an HRCT, it showed a ground glass opacity. It's not very characteristic of TB or sarcoid. Again, it is plus or minus. We can't believe the radiologist again. I should start on oral steroids. And again, since there was a little doubt of melanoma, ordered for an HRCT, and the radiologist gave this diagnosis of early uveal melanoma. We always think that radiologists are very, very clever people and they know much better than this. But not in this scenario. There is an RCS elevation. The fundus showed the progression of the lesion with oral steroids. So it is an evolving subretinal abscess. Again, did an FFA, ordered PCR. PCR turned out to be positive. Believe the PCR at least now, with zero mantle, with PCR positive, started on ATT and oral steroids. And look what happened. There was fibrosis and the retinitis showed a beautiful resolution both before and after treatment. Again, why this? I'm presenting this case. None of the investigations except the PCR. PCR reports, you know, dear friends, it comes in 2 to 3 weeks in my hospital, and some of the specialist centers you can request to come earlier. But in these 3 weeks, you are going to treat the patient. So what are you going to believe? So you have to believe, at least with oral steroid, there is a progression of the subretinal abscess. Then you suspect infection, and even with zero MAN2, we have to start with trial of ATT, and don't believe the radiologist diagnosis of choroidal melanoma. It is a tuberculosis masquerading as choroidal melanoma. And if you ask me how the radiologist gave a wrong diagnosis, are they wrong with T1 hyper, T2 hypo in the MRI? When you have a subtle looking neovascular vessels, which is so common in the tuberculosis, this T1 can become hyper, and the radiologist will just know there is a T1 hyper, T2 hypo, and this finding could masquerade as melanoma. So going to the comparison, and there was no systemic features unlike published, and we all know that TB can masquerade anything. What we all learned in all these 3 cases, response to treatment speaks 1,000 powerful words, and than any other investigations, including MRI. Thank you, dear friends. I invite all of you for the upcoming Hyderabad UVAT Society of India conference.
I just want to highlight 1 or 2 points. Subacute sclerosing panencephalitis is a very grave diagnosis, and in such cases, you should refer the patient to the neurologist, because there is a neurological involvement is quite very important in this case. And they should do the CSF analysis for the anti-measles antibody. And the treatment is now available. Otherwise, earlier there were a lot of patients died. Most of the patients died due to that. It's a very grave disease with a very rapid course. So you should be very careful. Second thing is that negative MAN2 is not a very unusual in case of tubercular uveitis, because in the disseminated tuberculosis, miliary tuberculosis, you get negative MAN2 test. So negative MAN2 will not shut down the possibility of tubercular lesion. And then hypoxia is quite common in case of tubercular uveitis, tubercular posterior uveitis. They can develop, I'd say anti-VEGF has been tried also in case of tubercular subretinal lesion, because they produce hypoxia and VEGF is liberated.